In this presentation, we will discuss about metabolic acidosis, metabolic alkalosis, respiratory alkalosis, hypokalemia, hyperkalemia, SIADH, hyponatremia, and hypernatremia. Metabolic acidosis is commonly classified according to the anion gap. This can be calculated by sodium plus potassium minus chloride plus bicarbonate. If a question supplies the chloride level, then this is often a clue that the anion gap should be calculated. The normal range 10 to 18 millimole per liter. In normal anion gap, metabolic acidosis chloride is retained to balance the charge of the bicarbonate ions which are lost. So it is also called hyperchloremic metabolic acidosis. Chloride is equal to 95 to 110 millimole per liter. So normal anion gap and raised anion gap. Normal anion gap is equal to hyperchloremic metabolic acidosis, in which bicarbonate loss from GIT, diarrhea, ileostomy, and ureterosigmoidostomy fistula, and bicarbonate loss from kidneys, renal tubular acidosis type 2 proximal, and drugs acetazolamide, tubular damage, and hyperparathyroidism, and decreased positive ion excretion from the kidneys, renal tubular acidosis type 1 distal, and renal tubular acidosis type 4, and ammonium chloride injection and Addison's disease. In the raised anion gap, DKA and renal failure and salicylides poisoning, alcohol, methanol, and ethylene glycol, and lactic acidosis type A and B. So next, metabolic acidosis secondary to high lactate level is subdivided in two types: lactic acidosis type A, which is shock, hypoxia, and burns; lactic acidosis type B, drugs, metformin, and tricyclic antidepressant. So next is metabolic alkalosis. Metabolic alkalosis may be caused by loss of hydrogen ions or a gain of bicarbonate. It is due mainly to problems of the kidney or GIT. So alkalosis is more unusual clinical than acidosis and has fewer causes. So maintaining alkalosis is also more difficult as the body produces significant amounts of acid each day during normal metabolism. So what are the causes? Hypokalemia, vomiting, aspiration, for example anorexia nervosa, peptic ulcer leading to pyloric stenosis, gastric outlet obstructions, and nasogastric suction. Next is diuretics, burns, liquorice, and carbenoxolone, and Cohen's primary hyperaldosteronism, Cushing syndrome, Bartter syndrome, and congenital adrenal hyperplasia. So what is the mechanism of metabolic alkalosis? Actually, its activation of renin-angiotensin 2 aldosterone system is a key factor. So aldosterone causes reabsorption of sodium in exchange for hydrogen in the distal convoluted tubule, and extracellular fluid depletion, vomiting, diuretics will go sodium and chloride loss, and activation of the renin-angiotensin 2 aldosterone system, which raise the aldosterone levels. In hyperkalemia, potassium shifts from cells to extracellular fluid. Alkalosis is caused by the shift of the hydrogen into the cells to maintain the neutrality. So next is respiratory alkalosis. Causes of respiratory alkalosis are central causes like stroke, meningitis, and CNS tumor, drugs, salicylates, and anxiety and pregnancy. So hypokalemia and acid-base balance. Potassium and hydrogen can be thought of as competitors. Hyperkalemia tends to be associated with acidosis because as potassium levels rise, fewer hydrogen ions can enter the cells. So hypokalemia with acidosis and hypokalemia with alkalosis. So hypokalemia with acidosis partially treated DKA, and renal tubular acidosis and diarrhea and acetazolamide. If the hypokalemia with alkalosis, vomiting, diuretics, Cushing syndrome, and Cohen syndrome. So what is the magnesium deficiency? Magnesium deficiency may also cause hypokalemia. In such cases, normalizing the potassium level may be difficult until the magnesium deficiency has been corrected. So approximately a drop of 1 mole in serum potassium is equivalent to total body loss of 200 mole of potassium. So next is hyperkalemia. Plasma potassium levels are regulated by a number of factors including aldosterone, acid-base balance, and insulin levels. Metabolic acidosis is associated with hyperkalemia as hydrogen and potassium ions compete with each other for exchange with sodium ions across cell membranes and in the distal tubule. ECG changes seen in hyperkalemia include tall, tended T waves, small P waves, and prolonged PR interval widen QRS leading to a sinusoidal pattern and asystole. Causes of hyperkalemia. Firstly, exclude the pseudo-hyperkalemia, then recheck a fresh sample. Acute renal failure and metabolic acidosis, additions, rhabdomyolysis, massive blood transfusion, and drugs like aldactone and ACEs and ARBs, cyclosporine and heparin, and unfractioned heparin and the low molecular weight heparin beta blockers. Both unfractioned heparin and low molecular weight heparin can cause hyperkalemia. This is thought to be caused by inhibition of aldosterone secretion. Next, beta blockers interfere with the potassium transport into cells and can potentially cause hyperkalemia in renal failure patients. Remember, beta agonists, for example, salbutamol, are sometimes used as emergency treatment. Next is pseudohyperkalemia is known to be associated with essential thrombocytosis, and patients with essential thrombocytosis are at increased risk of gout, and any prescription of Lasix will only make the problem worse. Foods that are high in potassium, salt substitutes like contain potassium rather than sodium. Bananas, orange, kiwi fruit, and avocado, spinach, and tomatoes. The most appropriate initial therapy of hyperkalemia is protection of the heart by IV calcium gluconate, which acts within minutes and works by raising the depolarization of the threshold for myocytes. Other medical treatment to lower potassium level, cell shift is 15 units actrapid insulin in 50 ml, dextrose 50%, and salbutamol nebulizers and sodium bicarbonate for debatable can worsen volume uh, overload, especially in renal impotence and pulmonary edema. And the calcium resonium is an ion exchange resin which, when taken orally, prevents potassium from being absorbed in the diet. It acts to deplete the body of the potassium by preventing absorption and takes at least 24 to 48 hours to have effect. It is not suitable as emergency treatment. So, guidelines for surgery in patients with CRF suggests that surgery should be postponed until serum potassium level below the 5.5 mmol per liter, and also potassium should be monitored immediately after surgery and then again 4 to 6 hours later. Next is hyponatremia. Hyponatremia may be caused by the water excess or sodium depletion. Cause of pseudo hyponatremia include high blood lipid or protein. Hyperlipidemia, increase in serum volume as in nephrotic syndrome, or hyperproteinemia as in myeloma, taking blood from a drip arm, and the urinary sodium and osmolality levels aid making a diagnosis. So it is important to diagnose the pseudo hyponatremia because as the plasma osmolality is normal, no treatment is required. Urinary sodium more than 20 mol per liter, sodium depletion, renal loss, patient often hypovolemic, additions, diuretics, diuretic stage of renal failure, patient often euvolemic. SIDH, urine osmolality more than 500 mmol per kg, and the hypothyroidism. If the urinary sodium less than 20 millimole per liter, sodium depletion, extra renal loss like diarrhea, vomiting, sweating, burns, adenoma of the rectum. Water excess, patient often hypervolemic and edematous. Secondary hyperaldosteronism, heart failure, cirrhosis, and reduced GFR, renal failure, and IV dextrose, psychogenic polydipsia. SIADH syndrome of inappropriate antidiuretic hormone secretion causes. SIDH is characterized by hyponatremia secondary to the dilutional effects of excessive water retention. Its criteria is normal renal, normal adrenal, and normal thyroid, and hyponatremia less than 135 milliequivalent per liter. Hypotonic plasma osmolality less than 270 milliosmol per kg. Inappropriate increased urine osmolality and increased urine sodium more than 20 milliequivalent per liter. So what are the causes of SIDH? Category malignancy, examples like small cell lung cancer and also pancreas and prostate. Neurological stroke, subarachnoid hemorrhage, subdural hemorrhage, and meningitis, encephalitis, and abscess. Next is infections like tuberculosis and pneumonia. Some drugs can also affect, like sulfonylureas, selective serotonin reuptake inhibitors, tricyclic antidepressants, carbamazepine, thiazide, vincristines, and cyclophosphamide. Other causes positive in expiratory pressures and porphyrias. Next, management. Connection must be done slowly to avoid precipitating central pontine melanolysis. Fluid restrictions and demetliocycline oral reduces the responsiveness of the collecting tubule cells to ADH. It will induces nephrogenic diabetes insipidus. It is used for SIDH when fluid restriction alone is inadequate. ADH vasopressins receptor antagonists have been developed, and the lithium induces nephrogenic diabetes insipidus but is not appropriate treatment for SIDH. So some also diagnoses SIDH, maintain the hyperkalemia and the suppression of renin-angiotensin system and no equal concentration of atrial natriuretic peptide and the normal serine creatinine, normal acid base and potassium balance and decrease BUN and decrease uric acid and decrease albumin. Next is antidiuretic hormone. Antidiuretic hormone is a nonapeptide manufactured in the supraoptic and the paraventricular nuclei of the hypothalamus and released secreted from the posterior pituitary. It acts on the collecting ducts, improving water permeability and hence water retention. It promotes water reabsorption in the collecting ducts of the kidneys by the insertion of aquaporin 2 channels. Carbamazepine as well as other agents such as thiazides and selective serotonin reuptake inhibitors may potentiate its release. Ethanol uses inhibits release. And antidiuretic hormones site of action is collecting ducts. Next is hypernatremia. Causes of hypernatremia: severe dehydration, diabetes insipidus, osmotic diuresis, and hyperosmolar non-ketotic diabetic coma and excessive IV salines.